Welcome to the Johns Hopkins Medicine online webinar series. Today, Johns Hopkins neurosurgeon, Dr. Raj Mukherjee, will be speaking about what to expect after brain surgery. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your email address will not be shared with any third parties, and we will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of the program for you to complete the survey. And now I would like to welcome Dr. Raj Mukherjee to begin our presentation.
So thanks so much, Amy, and thanks so much everyone for joining the webinar today. My name is Raj Mukherjee. I'm one of the assistant professors of neurosurgery at Johns Hopkins, and I also direct the brain tumor program at Johns Hopkins Bayview Medical Center. So the title of our talk today is slightly different than actually what's posted. So it is what to expect after brain surgery, but it's also what to expect leading up to brain surgery, because I think a lot of times there isn't actually a lot of time between when you get a diagnosis and when you're actually having a procedure. And within that period of time, what we wanted to provide was a resource so that you had a different perspective, basically, from a surgeon about what you should be thinking about, what you could be thinking about leading up to surgery, during that perioperative period, and in the long run. And so I hope this provides a resource for you, for friends, and for family now and in the future that you can go back to get some insight and guidance on how to work through this really difficult time in one's life. When someone has a diagnosis of a brain tumor or someone sees a brain surgeon, it's almost never pleasant. No one ever really wants to see a brain surgeon. Nevertheless, sometimes circumstances in life put us in that position. And again, hopefully this will provide some insight and guidance to you. As we go along, you'll see my email address at the bottom of most all slides, as well as the phone number for my office. So if you ever have any questions or concerns, don't hesitate to reach out. So I have no disclosures. And this is the overview of what I'm hoping to talk about during this time that we have together. So first is dealing with the diagnosis. Like I mentioned, oftentimes the diagnosis comes out of the blue, or it can really be a shock. And so I wanted to provide some principles, some guidance on how to get through that time period. Preparing for surgery itself, the time between diagnosis and actually the day of surgery. I wanted to go through what the day of surgery is actually like so that you can get a sense of what to expect. And some of the pictures that you'll be seeing in this portion of the procedure, or this portion of the talk, I should say, go through where your procedure is actually going to be done, the operating room and the waiting area, the ICU, the usual post-operative room that people that are treated at Johns Hopkins Hospital would see. And I wanted to show you that so that you have that as a reference point. I also wanted to go through some of the particulars about the initial recovery, and that includes post-operative day 0, the day of surgery, post-operative day 1, day 2, and the first couple weeks after surgery, as well as some general thoughts on long-term management and what might be a new normal for you or for your loved one. A lot of these topics are going to be a little bit dependent upon how you are, how fit or unwell you are, what symptoms you're having, what the diagnosis is, what kind of surgical approach is going to be taken. Nevertheless, there are some principles that I think would be helpful to anyone and everyone who's going to be approaching a neurosurgical procedure on the head or on the cranium. So with that, we're going to start with dealing with the diagnosis. So there are a lot of different ways that people present with a brain tumor. And some of the standard symptoms that can present include having a seizure, which can mean loss of consciousness, shaking, even frothing at the mouth. It can be really, really traumatic. It can be really, really disconcerting to someone who's seeing the seizure. And oftentimes, if it's a first-time seizure in particular, the ambulance is called, medication is given, and a person's evaluated in the emergency department, where some imaging shows a brain lesion. Some other ways that this can present include weakness, and sometimes that develops not all of a sudden like a seizure, but sometimes that develops over the course of weeks or even months. And so folks that may be noticing some subtle hand weakness, leg weakness, it may be a sign of many things, but one of those things could be a tumor. The motor part of the brain is right next to the sensory part of the brain. And so if someone's having sort of odd sensations in their face and their arms and their legs, in their body, that can sometimes be a sign of something going on in the brain. And particularly when a lesion is on the left side of the brain in certain areas, a person can present with speech changes. So difficulty understanding language or difficulty expressing language. Oftentimes, more and more in the more recent past, these brain lesions can actually be found incidentally. So say someone has a fall, what they call a mechanical fall, they just sort of tripped and fell, got a head scan, and all of a sudden you see a lesion. Doesn't mean that a person needs surgery right away, but it at least needs to be followed up. And so there are a lot of symptoms that are somewhat specific to a brain lesion, but more and more we're finding these lesions incidentally. When a person presents with seizures, or when a person presents with symptoms, or has some episode, oftentimes they are seen either in an emergency department or hospital, or in the clinic setting. It just kind of depends on how acute, how the time course of their symptoms. So if it's something like weakness that's been going on for weeks and weeks, it may be something that you see your primary care provider in a clinic, you have some imaging and are seen by a neurosurgeon. If it's something more acute, like a first-time seizure, you may be taken straight to the emergency department. And I think that plays into some of the logistics of how your workup and management and possible surgery might develop over time, depending on whether you're initially seen in clinic or in the hospital. Either way, if you're having symptoms, the most common thing to do would be to get imaging of your brain. The first type of image that we get is a CT scan. It's usually a quick scan that's done. It lasts less than 5 minutes or so. It's really good at looking at blood in the brain, or sometimes ischemia, like a stroke in the brain, as well as really, really obvious masses. But it's an initial surveillance picture. So if everything looks great on a head CT, oftentimes you can just be seen as a follow-up, and nothing urgent would be done. Now, if they see a mass on a CT scan, you would likely get a follow-up MRI, ideally with and without contrast, because by giving contrast, we can identify certain types of lesions that are sometimes a little bit more concerning. So that imaging might be a CT scan or an MRI, and the decision of which to get and when is really a decision that's up to the primary physician or provider that's seeing you, as well as obviously how you feel about things as well. Now, after you get that image, depending on what that image shows, we can go one of two ways in terms of how to proceed next. So the most non-invasive thing to do would be just surveillance, to watch and wait, maybe get another picture, in the coming weeks or months, depending on what we're looking at. If it's a large lesion that's symptomatic, one would be more likely to proceed or recommend a procedure. That could be a biopsy or a resection, oftentimes by what they call a craniotomy, which is the standard type of operative approach to biopsy and to take out brain lesions. Now, there are many things that play into whether we recommend surveillance or an invasive procedure. And some of those factors include the appearance of what we see on the diagnostic imaging. Some things just look more benign than others. And we can get a really good sense based on, especially an MRI with contrast, whether it's the kind of thing that we can watch, broadly speaking, or whether it's something that we would need to proceed on. The size is also important, the size of the lesion. So if it's small, generally speaking, it's something that we would watch. If it's something sizable, it was something, generally speaking, we would want to know what it is, especially if you were having symptoms. And we always have to obviously take into account the person's age and their frailty. And there are different frailty scores, for instance, that actually our team at Hopkins has led national efforts to try and determine how frailty, more so than age, is a main predictor of how someone does after surgery. Another thing to just broadly be aware of is that things may change a little bit depending on whether some of this imaging is done on an inpatient basis or an outpatient basis. So if you have a sizable lesion that had symptoms and you were brought in through the ED, there may be more concern about just getting a procedure done sooner rather than later. If it's a small lesion that is incidentally found, it may be something that you are seen in clinic. And in that case, you may not need to have something urgently done. And then something that's always in the back of our minds, and especially in the back of my mind, is availability. So even if there is something that we know that you need to have a procedure for soon, there's good data that shows that broadly speaking, you don't want to have surgery in the middle of the night or on the weekend if you don't need to. You want to have your A team around. You want to have the best anesthesiologist, the best scrub tech, and you want to have your surgical team be fresh and ready to go, not just randomly whoever's on call that day. And so sometimes when I see patients and I know that they're going to need a procedure, but maybe the availability of the operating room isn't perfect, or the perfect anesthesiologist for that case isn't available. Sometimes we'll talk about the logistics of maybe bringing someone back in short order in a week or two to make sure that we get them the absolute best care by the best providers in our system. In terms of dealing with the diagnosis, we talked about size. And so what you see here is a lesion that isn't in the brain itself, it's more in the covering of the brain. And so what you see here is a sort of front view of the head where we're looking at the patient's looking back at us. You can see the ears are over here and here, and this is the top of the head. And generally speaking, you want things in the brain to be symmetric. So you have one ear over here and one ear over here. You have a fluid part of the brain called the ventricle about here, and you have a fluid part of the brain called the ventricle about here. Now, if you split the brain in half, broadly speaking, it looks about the same on this side relative to this side. Aside from this, very obvious difference up top. And so this seems to be growing from not the brain itself, not the gray brain itself, but from the covering of it. And so this looks like what they call a meningioma. And it's a relatively small meningioma. And so this may be the kind of thing, especially if it was incidentally found, that we may just continue to watch. Now, if you look at this, a person that comes in with this kind of lesion, it's a little bit bigger, maybe putting a little bit more mass effect on the brain. And, this may be a little bit of a less comfortable decision to continue to watch at this point. If you compare it to a lesion like this, very large, a lot of mass effect, presumably causing symptoms, this is something that would be based on the imaging, it would cause us to be talking about surgery, straight off the bat, as opposed to, watching something that is a bit smaller. So, the size of a lesion is a really critical, important factor. Another factor is where the lesion is. And so, like I mentioned earlier, this lesion seems to be coming from outside, still in the cranium, in the head overall, but outside of the brain itself, and consistent with a meningioma. As opposed to this lesion here, seems like it's part and parcel almost of the brain itself. And so, broadly speaking, lesions that come from the lining of the brain, like meningiomas, don't need to have surgery as urgently as something within the brain itself. Especially, you can see there's areas of bright and darkness. And broadly speaking, a lesion like this, we will want to make sure what it is. It sure looks like what they call a high-grade glioma, which is the type of thing that you ideally would want to biopsy in the same setting of a resection to try and get out as much of this material as you can. And oftentimes these patients would need chemotherapy and radiation after the procedure. And it's something that we'll talk about in broad strokes towards the latter part of the talk. But just getting this imaging tells us a lot about the presumed diagnosis. Even without getting a pathological specimen, we have a really good sense of what type of tumor this is and how best to proceed. Now, when we get imaging of the brain, you can see here, just like I mentioned before, you want to look for asymmetry. So there's something obviously on this side that we don't see on the other side. And sometimes when we get imaging of the brain, we want to verify that there aren't similar lesions elsewhere in the body. And for this patient that had what they call an ependymoma, something that, depending on its size and shape and symptoms, we could sometimes watch as opposed to doing upfront surgery. In these patients with ependymomas and another category called subependymomas, we often will get spine imaging just to make sure that there aren't other lesions. And if there are, at least we can follow these things over time. So, oftentimes you're not just going to get an MRI of the brain. Oftentimes you need imaging of what they call the full neural axis, which is the brain, your cervical spine of the neck, thoracic spine behind your chest, lumbar spine, and your lower back. And like I've sort of alluded to, there is this continuum based on the imaging and other factors. So on the most non-invasive side of things, if all factors are favorable, sometimes we can just do surveillance, watch and wait. And when we take that approach, oftentimes if it's a benign appearing lesion, we'll get imaging in 2 or 3 months or so, and then yearly as a surveillance. Some people ask, well, why just continue to watch it? If the natural history of these lesions, like a meningioma, is to grow slowly over time, why not just take it out? And while that's possible, there are issues that can happen in surgery. It can cause at a minimum fatigue, an incision and scar issues. And so the general thought is if something is small and benign appearing and we can watch it, sometimes those lesions don't grow. And if they do grow, only slightly, sometimes we have other non-invasive approaches like radiation that can keep some of those lesions at bay. So depending on the lesion, the most non-invasive thing to do is surveillance, and it's always something that you should ask your providers about. On the other end, the most invasive thing that we can do is a procedure, including surgery. Like I mentioned, it really depends on the diagnosis, patient demographic factors, and the like. There are always options in between to at least consider, but depending on the lesion, it may not be a viable option up front. So for instance, when it comes to meningiomas, at least in the current state of medicine, we don't really have a medicine or a chemotherapy that can treat a meningioma. And the mainstay of that treatment is really treatment for those tumors is surgery and radiation. And chemotherapy, by and large, is saved for tumors that have already had diagnosis and have already been at least partially resected. Radiation, like I alluded to earlier, can sometimes be deployed in small benign lesions that are growing to kind of keep it at bay. And for more malignant tumors, like a glioma that I mentioned earlier, sometimes radiation is done in concert with chemotherapy after surgical resection. And so while medication or chemotherapy and radiation are theoretically options, practically speaking, when it comes to brain tumors, oftentimes the upfront decision point is about surveillance versus surgery. And like we alluded to before, it's all of these factors that really play into that role, aside from, the availability of the optimal team and the setting in which you're sort of being seen. Once you get all of that information, which is a lot, presumably you've been told you have a brain tumor, you're in the hospital or clinic, and it's an anxiety-provoking kind of a thing to be told that, if you're feeling well or just starting to have minor issues, that all of a sudden you have a brain tumor. And so oftentimes the next step is to just have a conversation with your loved ones, with your spouse, with your children, with your siblings, to get a sense of where everyone's head is at. We're more than just MRI findings, we're more than just CT findings. We're human beings, and we have feelings and we have thoughts and we have relationships, and all of those things matter. And I think trying to take things from a holistic perspective is amongst the most important things that you can do, especially early on. And I know here at Hopkins, we really pride ourselves in being very patient-centered and family-centered. And so, we don't want to do anything just to treat a picture. We want to make sure that we're treating and addressing the needs of the whole family. So oftentimes, whether it's in the clinic or in the inpatient setting, it's just a critical point. And another point that I think is really important is, and I'm saying this as a surgeon, is I think it's a good idea to get second opinions. Oftentimes people will send their imaging and their records of their history to us at Hopkins for a second opinion. We're one of the largest brain tumor centers in the country, if not the world, and I think it's part of our mission and it's part of our job to provide that second opinion and that feedback. I think it provides people a lot of comfort to know either that what their primary team is doing has been checked off or blessed or felt to be in the same appropriate direction by us at Hopkins. And sometimes we can provide some unique insights, either by finding something unique on the imaging or just being thoughtful about other operative or treatment approaches. One of the things that we do really well here at Hopkins is minimally invasive approaches to deep-seated brain lesion into skull-based lesions. So historically in neurosurgery, one would have a really large craniotomy, an incision on the head, taking off a big piece of bone, with a lot of brain trauma and recovery secondary to that approach. And I think one of the things that we've really done a good job over the last decade and more has been, really championing some of these minimally invasive approaches to brain tumors and to skull-based tumors. And so sometimes just that insight can provide a window of opportunity to do things maybe in a safer way, in a more gentle way for folks that do need to have a procedure. And so after you have that diagnosis, after you've gotten the imaging, after you've talked with your family, after you've had second opinions, there is that part, and it's often very anxiety provoking, especially if it's in the clinic setting where you're preparing for surgery. Now, in the inpatient setting, preparing for surgery is, having medical clearance within a day or two, getting an image prior to your procedure, and then just having the procedure done. And usually that means that, a person's having major symptoms with a large lesion. Now, if you're in a category where you are being seen in a clinic, you'll first be connected with a clinical coordinator who will call you and set up a clinic appointment. When you come to that clinic appointment, sometimes that can be done via telemedicine these days, or in person. You'll have a basic set of things done. You'll have your vital signs taken. You'll have, your history reviewed, including allergies and medications. You'll oftentimes see someone like a physician assistant to get an initial assessment of your history and some of your symptoms, and then you'll see the surgeon. And that's where a lot of the things that were reiterated earlier will be reinforced, and it'll give you a chance to look through your images with the surgeon so that you can hopefully have a better sense of what the presumed diagnosis is and what the treatment plan is, oftentimes surgery. My goal always is to make sure that whatever knowledge I have gets transferred to the patient and to their family. There shouldn't be a false barrier, and there shouldn't be a huge differential in terms of knowledge about what is being addressed. It's got to be a shared decision-making process. And the component that I can bring to people is my knowledge and understanding of anatomy and biology and pathology. And what you can bring to that conversation is your hopes and dreams and your wishes for how you'd like to proceed, given that we're going to be talking about some serious things, including operative approaches to your brain. And so we all have something to contribute. And I think it's really open. I think it's really important to have an open dialogue with your surgeon and to be really thoughtful and genuine. And hopefully your surgeon is as well. I know I pride myself on making sure I have an open relationship with every patient and family. If a shared decision is made about proceeding with surgery, we're going to need to do some things to make sure that you're optimized. And so it can include getting a chest x-ray to make sure your lungs are okay and your heart is okay. Maybe having you see a cardiologist if you've had cardiac issues or heart issues. Oftentimes that includes stopping some blood thinners, things like aspirin, Plavix, ibuprofen for at least a week or so before the procedure, so we don't cause any excessive bleeding. And to get other clearances, and that, especially in the modern age, includes getting a COVID-19 test, usually within a couple of days of the procedure. Now, if a person does test COVID positive, the best data that we have now shows that ideally one would defer surgery for about 6 weeks or so. Just because there is data from the general surgery literature that if you operate on someone within 6 weeks of being COVID positive, they have other issues, not necessarily in the brain, but when it comes to breathing and developing clot issues after surgery, it's more prevalent, it's more of an issue amongst patients that have recent COVID. So that's the reason that we run that test. And you just want to be very open with your surgeon and your clinical coordinator to just make sure you're on the same page about that. But if your surgery does get deferred because of COVID, because of a positive COVID test, it doesn't mean anything bad. It just means that you're going to have to just be in communication with that surgical team. And then always the day before a procedure, we get a special MRI, and that's called a WAND protocol or fiducial protocol MRI. And what you're going to have, it's going to be very similar to the initial image that you got, the initial MRI that you got. But you're going to have these little sticky markers put on your forehead, in front of and behind your ears. And those little markers are called fiducials. And what they do is they help provide us reference points in surgery so that we can be as precise and as targeted to get to the lesion and get out as much as we can. It's basically like an intraoperative GPS system. And so some people say, well, why do I have to get this other MRI? And while it's not absolutely mandatory historically, since we have it, and since it does provide, it does allow us to often have a smaller incision and a smaller operative corridor, I think it is better for patient care. And so I know for all of my patients, I have them get that special MRI the day before the procedure. Some of the other things to just be aware of when you're preparing for surgery is usually the day before the procedure, you will have, you'll be asked to do a chlorhexidine or an antibiotic scrub, shampoo basically. And that's something that we would send to you. And this is just a big meal. You want to make sure you eat well, rest well the day before the procedure, because it's going to be a long day, the day of the procedure. And if you can, it's always nice to not smoke. Now, the day of surgery, I'm going to go through that relatively briefly. I want to go through some of the particulars, and the pictures you're going to be seeing are actually from Johns Hopkins Hospital, which is one of the places where I operate. So the day of surgery, you're going to come in about 2 hours prior to the actual procedure. So if you have a 7:30 in the morning start time, we actually want you at the hospital at about 5:30. And so you would come into this area. This is an area, a reception area. So you'd come and you check in at this front desk. You will see a coordinator like this and let them, you give them your ID, just make sure you are who you are. They'll give you an ID badge for your arm, and then you will head back into the preoperative area. And so they're all private areas, but it'll be something like this where there's a little stretcher. One of the nurses will come by and check your labs and your medications, make sure you didn't eat anything since midnight. You'll also see the anesthesiologist, and you'll see one of the surgeons like myself to go through a consent. So you'll get into a gown, and there'll be some downtime, but that's all going to happen between 5:30 and 7:30 in the morning. Once it gets to 7:30 in the morning, or whatever your start time is for surgery, you'll head into the operating room, which I'll show you momentarily, and your family will be in a waiting area like this. While they're in the waiting area, there will be a board, and on that board, there is going to be a number that is assigned to you. So your name won't be on there, but a number will be assigned. And then based on the color coding, it'll say that you're either in surgery if it's green, in the post-op area if it's purple, you're in the ICU if it's red and all done with surgery. So you'll have a mechanism to generally have a sense of how your loved one is doing or where they physically are. And about every hour or two during the procedure, one of the circulating nurses in the room with me or with the surgeon will give you an update, usually via text or phone call. This is what one of our operating rooms looks like. This is the anesthesia station over here. The circulating nurse is going to be off to the side. This is one of the operating rooms. We have lights, and there's a lot of other things in here that actually aren't included in the picture, including a microscope and a lot of other equipment that we use just to make sure that things are safe and optimal. After surgery, most folks will go to the ICU, the intensive care unit. This is actually one of the pictures of our intensive care unit. They have big windows, so you can get a lot of light in the room. There is neuro monitors and everything necessary for a modern ICU. On these screens, it allows the nurses who are going to be treating you either one-on-one or one-on-two, meaning that maybe treating you and the patient in the next room so that they can have all the information that they need. There's going to be dozens and dozens of people taking care of you. So that would include myself as a neurosurgeon, an intensive care doctor, the nursing staff, and all of our support staff, including many physician assistants, residents, fellows, and the like, and students. Each nurse is going to carry a telephone. So, say you're not with your loved one, but you'd like an update, we can always provide you the phone number to that phone, so you can have up-to-date information and knowledge throughout the day. After that first day in the ICU, usually you would transition upstairs to what they call a regular floor bed. And again, these are all private rooms. They all actually have great views. They also have reclining chairs, which are helpful to make sure that you're mobilizing and getting up and out of bed. We really pride ourselves on being very patient focused and patient centered. So, don't hesitate to push this nursing button, which will get you in touch with one of the nurses or someone at the front desk right away. And for family members, there's an entire clinical care team that will help make sure that you're comfortable, you and your family are comfortable and getting everything that you need. Some of the things to be aware of the day of surgery and in the coming days would be, and this is something to ask your surgeon about, because sometimes when it comes to a hair shave, sometimes we have to do a big hair shave, sometimes we do a small hair shave like this, and sometimes we do none. And it just kind of depends on the operative approach. The incision can be big like this, very small, which is just a component of this, or sometimes no incision. And, there are certain tumors that I do through the nose where there is no incision. It's also a good idea to ask your surgeon about whether you're going to have staples like in this picture or stitches to close your incision. Oftentimes, if the incision is behind the ear or in the back of the head, we'll have stitches. And oftentimes, if it's on top of the head, we'll have staples. Another thing to sort of be aware of there's something called Mayfield pins. So we don't want your head to move during surgery. And so while you're asleep, we put your head in a frame basically called a Mayfield pin system, just to make sure you don't move too much. Almost always we will have a Foley catheter, which is a urinary catheter, as well as IVs in an A-line placed as well. These are things that will come out in the coming days after surgery, but it's good to know you're going to have them just so that it isn't a shock when you wake up. And some final thoughts here as we get towards the end on the initial recovery, going into some more details. On the day of surgery afterwards, you're going to have a lot of lab work done. You're going to probably get a head CT. And you're going to be a bit groggy. And every hour or so, especially while you're in the ICU, the nursing staff is going to check on you just to make sure you're doing well. Doesn't mean anything bad happened during surgery, but it's just a routine part of practice. And once we get you all settled, you should be able to spend time with your family, friends, and loved ones, although you are going to be pretty groggy probably from surgery. Now, on post-op day 1 and 2, you're going to be eating, you're going to be getting up and out of bed with physical therapy, with nursing, maybe even with your family, just depending on what your baseline state was. So if you came in walking, talking, and doing well before surgery, almost certainly that's how you're going to be afterwards. If you came in with some issues prior to surgery, including with mobility, you may need some help getting up and out of bed, and you may have a recommendation of, say, going to a rehab facility to get stronger before heading home. But for folks who were walking, talking, and doing well before surgery, usually they would head home by post-op day 2. So if you had surgery on a Monday, you'd be heading home on Wednesday. Thereafter, in the first 2 weeks, people will often get fatigued, especially in the first week just from anesthesia. But that's something that gets better over time naturally. And I think by walking, by staying fit, by eating well, those are all things that can help in the couple weeks after surgery to help you get over that fatigue. And during that 2-week time period, you're going to have a lot of appointments. So you're going to have an appointment with me or one of the neurosurgeons to take out staples or stitches. By that point, you should have the pathological slides, like the diagnosis of what the tumor is, finalized. And based on that, we can discuss some next steps. So if it is, for instance, a meningioma, a low-grade meningioma, oftentimes that's the kind of thing that we would just get surveillance imaging on in 3 months or so, and then yearly. On the other hand, if it's something like a glioma, oftentimes after that 2-week recovery period, we would refer you to an oncologist and a radiation doctor to discuss next steps, which would include chemotherapy and radiation. That often lasts for 6 weeks or so. And it starts a secondary, what they call adjuvant treatment protocol. And once you get past that protocol, it again goes back to surveillance, usually imaging every couple months or so. In terms of long-term management, almost certainly you'll have a new normal, and hopefully it's in a positive direction. I think a lot of that long-term management involves a multidisciplinary care. Here you can see many of our providers in neurosurgery, as well as ENT, or ear, nose, and throat otolaryngology, who are often our surgical colleagues. We have colleagues in the Eye Institute from radiation oncology and oncology, as well as endocrinology. And oftentimes depending on what tumor type you have, you'll interact with some or all of these providers in both the short term and the long term, oftentimes eventually with just surveillance imaging and surveillance checkups. While early on, there's going to be a lot of appointments and communication, including a lot of diagnostic imaging. The goal is to get you back and better than ever. And I think if we're thoughtful about the approaches we take and are cognizant of what your needs are, that, that's often something that we can get for people. Our mind is presumably housed in our brain, and secondarily, the crux of who we are as people is, as far as we know, centered in this brain, this most amazing organ. And so, it's not just treating a picture, it's treating a person and treating a family. And we really want to be holistic in our approach, both in the short term and the long term. So these are the topics that we talked about in terms of from diagnosis, preparing for surgery, surgery itself, and the aftermath. These are some references. Happy to take any questions. And my contact information again is here on the bottom. Don't hesitate to reach out anytime if you have questions, concerns, would like a second opinion. We're always happy to help however we can. And so with that, I'll leave this slide set up, and happy to take any questions.
Thank you, Dr. Mukherjee. So just a reminder, you can submit your question through the Q&A box at the bottom of your screen. And so we do have a couple questions here. Our first question is, what type of treatment will be used to help reduce any swelling of my brain after surgery?
Yeah, so that's a great question. So there are a couple things that can be done. In terms of medication, oftentimes we will give a steroid, something like dexamethasone, otherwise known as Decadron. So in the short term, steroids are almost always great. They decrease swelling, they help people feel better. In the longer run, some of the side effects include that steroids can cause people to be a little bit jittery, and they can cause your blood sugar levels to go up high. And if you're on steroids for a long period of time, it can cause weight gain and other issues. So in the short run, steroids are something that can help with brain swelling, but we oftentimes will try to taper people off over, say, a couple weeks or so that they don't have the side effects. If they redevelop symptoms after that, we have to bump it up again oftentimes, but that's really the mainstay of treatment for brain swelling. We also can essentially give people salt or salt tablets. And the rationale for that is just like how when you put salt on a snail, it kind of shrivels up the snail. In the same way, if you give a person extra salt, it actually shrinks the brain a little bit, and that can help with some brain swelling. So there are medications that we can give from both a steroid perspective as well as a salt perspective. Those are the mainstays.
Great. Our second question, how will I know if I have any memory loss? Will I be assessed for that?
Yeah, so, memory is a complex function in the brain. And so it's not in any one particular area. Short-term memory tends to be more focused in what they call the amygdala and the hippocampus. It's the deep part of the temporal lobe, particularly on the left side. And so if you have a tumor in that area, that should be something that one of your surgeons will discuss with you as being a possible issue or complication. I know for myself, whenever I have patients with those types of lesions, I will have them have neurocognitive testing by a neuropsychologist and to get a baseline assessment, as well as to follow them afterwards. And if someone does have some deficits or some issues with memory, it's often good to reconnect with that neuropsychologist to repeat testing to get a sense of what the new deficit might be, as well as to help with some training exercises. So just like how if someone is weak in their arm, we do physical therapy to help it get stronger. Similarly, for the brain and for memory, there are some exercises that can help, but it's good to know what type of memory issue a person is having. So that's the broad answer. And then sometimes in the short run, especially in the first couple of weeks or so, along with the fatigue, sometimes people can have some memory fog. So I would say to some degree that would be expected within the first couple of weeks. But beyond that, especially if it's getting to be a couple months or more, I think maybe all the more reason to inquire about seeing a neuropsychologist for some testing and some tools.
Our next question is, what goes wrong with communication if temporal lobe has oligodendroglioma?
Yes, so I'm not sure I 100% understand the question, but I think the oligodendrogliomas are a type of tumor. They're a type of glial tumor. And so remember I mentioned there were meningiomas and gliomas. And gliomas tend to be the type of thing that we would want to operate on, because if we don't, they tend to get aggressive. And so oligodendrogliomas, they're a subtype of glioma. they tend to be in the temporal lobe. And especially if they're in the ventricle, in and around the ventricle, the fluid part of the brain that I showed in one of those pictures where there was that, what we called an ependymoma or subependymoma. It's a fluid part of the brain. And so, that fluid part of the brain does tend to be near the memory part of the brain. It can, some of that tumor can physically block some of the brain fluid, and that can cause some problems. But it may be the kind of thing that I may not be honestly fully addressing your question. So it may be the kind of thing, if you send me an email, I can try and maybe give you a more specific answer. But broadly speaking, oligodendrogliomas, depending on their location, can cause issues. Temporal lobe specifically can cause some fluid backup and memory issues, or even some speech issues if it's on the left side. So I hope I partially answered your question, but please don't hesitate to reach out. And I'm happy to give some more details.
Our next question is seizure medications always necessary after surgery?
So that's a great question. And to be honest with you, we don't have great what they call level 1 evidence. So we don't have a randomized controlled trial of patients on or off anti-seizure medicine after surgery. But I think if someone presents with a seizure, generally speaking, I and many others will keep people on anti-seizure medicine at least for a couple months or so after surgery, just because there can be brain irritation from the surgery. And thereafter, at least I will have someone see a neurologist to run an EEG, a test to see if there's still brain irritation after a couple months. And if there isn't, then we taper it off. For someone who does not have a seizure disorder, didn't present with seizures before surgery, I usually keep people on it at least for a couple weeks or so, if not maybe a month or so, and then taper off. There's no great data for that, to be honest with you. A lot of the best data that we have shows that if you're going to do something in and around the brain, it can cause irritation oftentimes for the first week or so. So at a minimum, you should probably be on anti-seizure medicine for a week after surgery. Thereafter, it's a little bit at the discretion of the surgeon as well as you to see, some of the risks and benefits. So I hope that helps a little bit.
Our next question, how soon after surgery can I dye my hair again?
Yeah, wonderful question. I think, there's no randomized trial for this, but the best data that we have from the plastic surgery literature says that the tensile strength of the skin, meaning how well your skin approximates, gets to about 90% or so within 2 or 3 weeks of surgery. So theoretically, and that's why we tend to take out stitches and staples about 2 or 3 weeks after surgery. Because it has good tensile strength by then. So my personal rule of thumb is, definitely no sooner than 2 weeks. You want to wait at least 2 weeks before you dye your hair, just because there are some products that could be, some dyes that could be irritating to that relatively raw skin. And after we take out the staples, I usually say wait another week or two, just to make sure that things don't, pop open or become problematic. So for me, I say about a month, but I'd say for anyone, no sooner than 2 weeks, just to be safe.
Our next question is, how long does it take for the surgical wound to heal?
Yeah, so like I was sort of mentioning, at a minimum, it takes about 2 weeks or so. If you've had surgery before and someone is reopening the same incision, in those instances, it does take a little bit longer to heal. And so that does take maybe even 3 or 4 weeks. But for a first-time incision, I would say 2 to 3 weeks is the standard for getting about 90% of the strength back. And thereafter, it'll probably never get 100% as good as if you never had an incision, but it can get pretty close. So I would say about 2 weeks is the usual time to heal. I think I saw the question was, is it painful when the staples come out? So not really. I mean, sometimes you'll see someone that has a dozen or so staples if it's a long incision. And so the way it works is it's essentially a staple remover. And so if you have your skin here and your staple, it basically flanges out the edges of the staple. And so it feels a little, what I've been told is that it feels a little, you feel that it is there, you feel some pressure, but it shouldn't be painful. If it's painful, tell the person who is taking them out, because that's not a usual thing. I think, Amy, I'm sorry, were you gonna?
Yeah, Our next question is, with glioma and initial resection, do tumors just come back but more aggressively?
Yeah, so that's a great question. So amongst the gliomas, there's actually a family of gliomas. And the main hierarchy is a grade 1, 2, 3, or 4 glioma. And so generally speaking, grade 1s and 2s are called low-grade gliomas, and grade 3 and 4 are called high-grade gliomas. So the majority of people have high-grade gliomas, unfortunately. And so those are the kind of tumors that even if you get out all of it, the natural history of grade 3s and 4s are that they do progress, oftentimes in several months, in 6, 9, 12 months. And they do become oftentimes a bit more aggressive. And when that happens, depending on the specifics of the lesion, when it progresses, how a person is doing, and some of the molecular markers associated with that glioma. Sometimes it's a good idea to do another resection. Sometimes it's a better idea to do chemotherapy or radiation. And oftentimes when they recur, you will be referred by your neuro-oncologist to be discussed at what they call a multidisciplinary tumor board. And so that's where neurosurgeons, neuro-oncologists, radiation doctors, pathologists, radiologists, the whole slew of experts from Johns Hopkins, we actually meet every Monday morning to go over difficult cases like that, like progression of a glioma or recurrence of a glioma, to figure out what might be the best course depending on all of the specifics of that person. Again, age, how they're doing, their tumor status, their imaging. And so that's the majority of gliomas. I should say, though, that amongst low-grade gliomas, especially grade 1 gliomas, which are called pilocytic astrocytomas, grade 1s, if you get out all of that tumor, oftentimes you can just watch it. They actually don't come back. But those types of lesions tend to be in very young people. And so while that theoretically is a possibility, most gliomas do tend to come back. They do tend to be pretty aggressive. And they have a multitude of treatment options for which, connecting with neurosurgery and neuro-oncology in a multidisciplinary setting like a tumor board is probably the best bet.
Great. Our next question is, would it be possible to treat a 6 by 4 centimeter angiomatous meningioma without surgery?
So I think that's a good question. It depends a little bit on some of the details of what the imaging looks like, sort of what I was alluding to earlier, sort of how the person is doing, what their age is, what their frailty is. But broadly speaking, when someone has a sizable lesion like that, a 6 centimeter lesion, broadly speaking, a surgical debulking would probably be the best first approach. The only thing that gives me some pause with that is when it comes to meningioma, the only way we really know whether or not it's an angiomatous meningioma, subset of meningioma or not, is if we had pathology on it. So the sense that my sense is, because the question is talking about a specific type of meningioma, maybe it was the kind of a thing that was maybe biopsied or debulked before. And if that's the case, and that's the amount of residual that is there, or the amount that has recurred, at least getting an opinion about whether to do a surgical resection on that, because it is pretty sizable, would probably be a good idea. Now, is it possible to treat without surgery? The best treatments that we have non-surgically for meningiomas are sometimes radiation, but generally speaking, radiation is a bit more tricky, can cause a little bit more swelling if the lesion is greater than 3 centimeters. So I think radiation may be something to consider. I think chemotherapy and immunotherapy options are usually kind of last line and almost a little bit experimental. And so I think the discussion would be between surgical debulking or radiation. And again, that's the kind of thing, especially if you've already had a biopsy or a partial resection or a resection in the past, something that might be worthwhile discussing in a multidisciplinary fashion. And again, something we're happy to look at here at Hopkins if you like.
Our next question is, what are the risks of a procedure for a 78-year-old?
Yep. Yeah, great question. I think actually a lot of the research that I've done on clinical outcomes research in brain tumor patients has been focused on trying to identify the different risk factors for age versus frailty. So not every 78-year-old is of the same health and of the same frailty. When you look just at age, what we found is that patients who are well into their 80s, 85 and above, tend to have higher risks when it comes to surgery. And so if you extrapolate from that, people, less than 80 years old, have a similar risk profile, at least compared to folks in their 60s. And actually, if it's a healthy 78-year-old, they actually may have a better risk profile, a better outcome, a projected better outcome than someone who's very, very sick and very, very frail, say in their late 50s. So overall, the risks are, I would say, probably similar. To people in their 60s and maybe even early 80s, which are, manageable. But some of the risks, to be specific, include, wound infection, bleeding around the site, and maybe developing a clot. Sometimes folks who are a bit older and maybe not as mobile can develop a blood clot in their legs just because they're lying down a little bit after surgery. So those are all risks, but there are similar risks when you actually look at the data, similar risks even in people who are a bit younger. I think the main issue is not so much age, but frailty. And that's something that we can help you risk stratify. If you just reach out and then we can figure that out, or just connect with your neurosurgeon and see their thoughts on that. But not necessarily any higher for someone relatively a little bit younger. Hope that helps.
Do you recommend I keep track of how I feel after surgery? And if so, what information does my surgeon want me to track?
Yeah, wonderful question again. I think there's a couple different ways of answering that. I think traditionally, we have tracked the types of symptoms that you had to begin with. So if you presented with seizures or weakness or aphasia, sort of a difficulty speaking or understanding, those would be the things that a surgeon would, or maybe issues with vision. Those are the kinds of things that a surgeon would want to know afterwards, as well as sort of general things like fatigue and how's your incision doing. I think a lot of actually my particular research is looking at quality of life in patients. And looking sort of beyond just those general things. And so oftentimes I will have patients in my clinic do a specific questionnaire, a quality of life questionnaire that looks at many different domains in their life, including are they, do they have enough energy to go up a flight of stairs, to walk for 15 minutes, to do leisurely activities with their family. And so that's something that I'm tracking because I think it's important. It allows me to be a little bit more holistic in how I manage and treat patients. It gives me important feedback. But I would say at a minimum, you want to let them know how your fatigue is, how your incision is doing, and how the symptoms that you had before surgery compare to how you are after surgery.
Are there any special diets or supplements recommended to help the brain heal?
Yeah, great question. I think people have looked at this in a couple of different ways. The first sort of broad piece of data is when it comes sort of very simply to healing, when it comes to incisional healing, it's important to have a good amount of protein in your diet. And that doesn't mean that you need to be eating only red meat, but having protein in some form or variety, whether it's from beans and legumes or meat itself. I think proteins help with healing at a biochemical level, help with healing, and so I think it's important to try and have some protein in your diet. When it comes to other diets, I think there has been some data that has looked at a ketogenic diet to try and quote unquote like starve a tumor, and so the best data we have for that doesn't seem to show any major correlation between being on a ketogenic diet and having better survival from a tumor perspective. And also a ketogenic diet can be somewhat difficult for people to stick to. And so for that reason, I don't particularly recommend a ketogenic diet specifically, but I think from a healing perspective, there's good data that having good protein can help you heal, especially your skin.
How can I volunteer to be part of a clinical trial?
Sure, that it's first of all, it's very kind of you to think about that. I think one of the reasons we have so many advances today in medicine is because people volunteered their time, their energy, their intellect, their wisdom to developing these trials and participating in them. And if no one volunteered, we would not be where we are today with survival and outcomes markedly better now than it was even a generation ago. So it's kind of you to offer and to think about being in a trial. I think, one of the easiest ways would be to just reach out to someone from Hopkins and just let them know that, hey, I have a such and such brain tumor and I would like to participate. I'd like to volunteer. Depending on what type of tumor you have or your loved one may have, there may or may not be specific trials for you to enter into clinically, where you're testing a certain medication or testing a certain treatment like radiation. At a minimum, though, even if we don't have a specific trial for your specific tumor type, I think there are a lot of natural history studies that track patients' quality of life and activity and those kinds of things. And so even participating in that gives us a lot of data and can help provide more focused care to people in the future. So I would say sometimes it can be a little difficult finding the right person. And so for whatever it's worth, you can always shoot me an email or call my office and we can get you pointed in the right direction.
Our last question we have time for today is, what minimally invasive brain surgery options are available?
Sure. Great question. Again, like I alluded to in the talk, I think it's something where Hopkins is actually really leading the field in this area. And so there are a couple things, a couple different approaches. And one approach is using something called BrainPath. It's a company name for it, for which I don't have any specific affiliation, but you can think of it as a tubular retractor device. And so traditionally you'll have an incision like that picture that you saw with a large incision like this, where you have to retract brain tissue using large retractors. And so a new way of getting down to the deep parts of the brain is actually using a little retractor system that's maybe about an inch or two in size. So you make a small incision, maybe a couple inches in size, and you use this little tubular retractor. It almost looks like a small roll of toilet paper. It's sort of between a pen and a toilet paper, somewhere in that size. And you use that to sort of push aside the areas of the brain gently to get down to where you want to be. We actually have a paper coming out demonstrating the utility of that approach in the biggest series to date, using that tubular retractor device. So that's something that is possible, especially for deep-seated tumors. And another broad area of approach, especially for tumors that are along the skull base, maybe not in the brain tissue itself, but in the skull base, is to use an endoscopic endonasal approach, which means to operate through the nose to get to lesions sort of at the base of the brain. And that would be sort of near your eye, near your ear, near your brainstem. And so, that's something that I and others do here. I think it's a good thing to be aware of. And again, happy to connect anytime about those kinds of things to see if it's a good option for you or not.
Great, thank you, Doctor. So that is all the time we have for questions today. If anyone is interested in scheduling an appointment, you can call the number on your screen, or you can do so by filling out the survey after the webinar. And we greatly appreciate everyone attending today. Thank you so much and have a great day.
Thank you, everyone.